Contrary to what Dr. Chandramohan would have you believe, I am not an expert in hereditary colorectal cancers, although I do have a fair bit of experience. While I was scratching my head how to cover the entire spectrum of hereditary polyposis coli, another bombshell was added by Madhu, who asked me to talk also about Lynch syndrome in the 12 minutes that I have. So I'll try to cover just the basics. I'm sure I'll be leaving out a lot of important things which we could always discuss. So we know that nearly a third of colorectal cancers patients have at least one family member who's been affected by the same. Broadly, hereditary colorectal cancers may be classified as polyposis syndrome or non-polyposis syndromes, and the polyposis syndromes may be adenomatous or non-adenomatous polyposis. And we all know that the risk of hereditary cancer syndromes are more if the patient is diagnosed at a young age, less than 50 years, or the early onset colorectal cancers. So the ones marked in red are the traditional hereditary adenomatous polyposis syndromes. The most common, of course, is the familial adenomatous polyposis. We also see a little bit of patients with MAP, that is mute by H associated polyposis. The other polyposis syndromes are more recently described and are not very common. You have non-adenomatous polyposis syndromes like the juvenile polyposis and the Peutz-Jeghers syndrome, and of course you have the so-called non-polyposis colorectal cancers, which is a misnomer because they do also tend to present with adenomatous polyps. So I'll just briefly describe two patients and then we can see how we practically approach these patients. So the first patient is a 68-year-old male diagnosed to have a cancer in the cecum. He had a family history. His sister died of colon cancer at an elderly age, 65. His sister's son was diagnosed to have colon cancer at 45 years. The colonoscopy report with which he came to us showed multiple smooth surface sessile polyps throughout the colon. There was no mention of the number of polyps. There were few pedunculated polyps in the descending colon and a large ulcerated polyp in the cecum, but there were no polyps in the rectum. The patient refused to undergo another colonoscopy. The biopsy from the cecal growth was a moderately differentiated adenocarcinoma, and from the polyps was a tubular adenoma with a low-grade dysplasia. So this was a picture that he came to us with. It showed fair amount of polyps, but we were not sure exactly how many number of polyps were there. The second patient is a 37-year-old male, again diagnosed to have a cecal growth. His paternal aunt had colon cancer at around 45 to 50 years of age. His colonoscopy showed an ulcerated growth in the cecum and the rest of the colon was normal, and the biopsy was an adenocarcinoma. So when we come across a patient with a colorectal cancer, unless we think of hereditary cancer syndrome, we will probably not evaluate in those lines. But normally in these two patients who have a family history of cancer, one is an elderly person, another is a young person. The four common questions that comes to our mind is, should you suspect a hereditary colorectal cancer syndrome in these patients? When and how do you test the at-risk relatives of a patient with either a suspected or a confirmed hereditary syndrome? In a patient who has a confirmed diagnosis of a hereditary syndrome, what is the risk of colorectal cancer and how do you screen for it? How do you prevent it? And finally, a patient with a colorectal cancer and a hereditary syndrome, how do you treat them? So I'll try to address some of these questions. So when do you suspect a hereditary polyposis syndrome? Any patient who has at least 20 adenomas, cumulative adenomas in their lifetime, or with other extracolonic manifestations of FAP like a CHRP or a desmoid tumor, or a patient who has a family history of a known patient with a FAP or an MAP, or in general any patient less than 50 years who presents with colorectal cancer. And when would you suspect Lynch syndrome? Earlier the Amsterdam 2 criteria was used, although it is highly specific, the sensitivity was low. There was an earlier talk on the revised Bethesda criteria, which is a much more inclusive criteria with a higher sensitivity but a less specificity. And it is more useful in identifying patients who would benefit from MSI testing or an immunohistochemistry for a deficient MMR. So if a patient presents with any of the criteria as mentioned here, you should probably suspect that the patient has got a Lynch syndrome. Now, is a positive family history a must for a diagnosis of a hereditary polyposis syndrome? The simple answer is no. Because at least 15 to 20% of patients present de novo without any family history. And in an autosomal recessive condition, you probably may not always be able to elicit a family history. So please do not be under the impression that only if a patient has a family history, you should suspect a hereditary colorectal cancer syndrome. So when you suspect, how do you confirm or how do you establish that this patient has a hereditary polyposis syndrome? It's a combination of the phenotype, that's a clinical features, and the genotype, which you establish by a germline mutation testing. So normally, a clinical diagnosis of FAP is entertained if the patient has got more than 100 adenomatous polyps distributed throughout the colon. Sometimes patients may present with less than 100 polyps, maybe around 30 polyps, 40 polyps. So you need to consider other polyposis syndromes like an attenuated FAP or MUT-YH associated polyposis syndrome or the proofreading associated polyposis syndrome, etc. But always remember that some polyposis syndromes in which you have a confirmed mutation or a pathological variant may present to you with very few polyps. The reverse may also be true. Some patients may have multiple polyps, but they still may not have any identifiable pathological variant. So these two things you must keep in mind. I'm not going to go into detail on the various colonic and extracolonic manifestations. All of you are very familiar with this. But having this in the back of your mind will help you at least suspect what possible hereditary cancer syndrome this patient could have. Usually the colonic polyps, the number is what you usually go by, but also presence of polyps in the other parts of the gastrointestinal tract, especially the duodenum. And you also need to think about other non-polyposis syndromes or non-adenomatous polyposis syndromes like the Peutz-Jeghers, where the patients more often than not present with intussusception because of the polyps. And Lynch syndrome, although it is termed as a non-polyposis colorectal cancer syndrome, these patients still develop adenomas, and the adenoma carcinoma sequence is still valid in such patients. So you should not think that the patient does not have Lynch syndrome just because he's got multiple polyps. Now, when you have the phenotype, how do you establish the genotype? When would you ask for a germline testing in a patient with a phenotype of a typical polyposis syndrome? So generally, any patient with more than 20 cumulative adenomas in their lifetime, they are candidates for undergoing germline mutation testing. You could also offer it to patients who have less than 20 adenomas if they have been diagnosed with colorectal cancer at an age less than 60 years, or if they have a family history of polyposis or colorectal cancer or any of the other extracolonic manifestations of these familial polyposis syndromes. But the chance of finding a pathological variant is only around 7% if the patient has got less than 20 adenomas. Now, again, the earlier speaker had referred to the pathway for testing for Lynch syndrome. You could have a universal screening with MSI or immunohistochemistry, or you could have based on selective criteria like the Bethesda criteria. So once you have done the IHC, how do you proceed? It depends on the loss of expression of one or more of the 4 markers that are normally tested while doing the IHC for mismatch repair genes. In a microsatellite stable, or if there is a low probability of microsatellite instability, then probably you don't need to test further. If there is loss of expression of MSH2 or MSH6, these are very typical for Lynch syndrome. You go straight away to germline mutation testing. Similarly, if there's an isolated loss of PMS2, again there is a high suspicion of Lynch syndrome. But if there's an isolated loss of MLH1 or combined loss of MLH1 and PMS2, then you need to first make sure that this is not a sporadic cancer. You either look for a mutation in the BRAF, or you do a promoter hypermethylation testing for MLH1, which is not commonly done. It's preferable to do a BRAF mutation test. And if there is no mutation, then you go ahead with germline testing. Nowadays, we use multi-gene panel tests, which usually covers most of the common hereditary colorectal cancer syndromes. ASCO has recommended a certain panel of genes that need to be tested while doing a germline mutation testing. So this saves a lot of trouble. You will be able to identify most of the hereditary colorectal cancer syndromes by doing these panel of germline mutation testings. The next question you would ask is, if a patient already has a typical phenotype, he's got around 100 to 200 polyps scattered throughout the colon. I'm strongly suspecting that this patient has got a FAP. So why do I need to do a germline mutation testing? It will still help by doing a germline mutation testing, because not only will it confirm the diagnosis, it facilitates the screening for the family members, and it may have predictive value for the extracolonic manifestations, and at times it might also help determine the extent of prophylactic surgery that you would need to do for these patients. So you can also come across situation in a patient who has a typical FAP phenotype, but you do a germline mutation and you find that there is no mutation. So what do you do then? It still does not rule out FAP, because the germline mutation testing probably does not cover all the known loci in the FAP gene. So it is recommended that you test specifically for APC promoter 1B, or you look for large frame deletions or insertions by doing an MLPA test. And in spite of all this, if you still don't find anything, you still treat this patient and his relatives as you would treat a patient with a established familial adenomatous polyposis. So now that you have identified that the index patient does have a hereditary colorectal cancer syndrome, what would you do to his relatives? Would you offer genetic testing for at-risk relatives, and how do you go about it? If it is an autosomal dominant polyposis syndrome, then all the first degree relatives must be offered the same germline mutation testing. You can, instead of doing the entire panel, you can just do a Sanger sequencing with the already identified mutation in the index patient. Whereas in autosomal recessive syndromes, the siblings will definitely need to be tested. Whereas the offspring need to be tested if the parents are consanguineous, or if the frequency of carriers of the pathogenic variants in the general population is higher than 1 in 100, as occurs in the MUT-YH associated polyposis syndromes. So what is the risk of hereditary of colorectal cancer in hereditary colorectal cancer syndrome? That is what we are most interested in, and that is what the screening and the prophylactic surgery, everything is aimed at, is to reduce the incidence and prevent colorectal cancer in these patients. The highest incidence, of course, is in FAP, where there's 100% penetrance. If you have the genotype, you are definitely going to have the phenotype, and you will definitely, if untreated, you are going to develop cancer. The risk of colorectal cancer reduces in the other hereditary syndromes. In attenuated FAP, you may have a risk as high as 70%. In Lynch syndrome, it depends on which of the mismatch repair genes is mutated. The highest risk is for loss of MLH1, and the least risk is for loss of PMS2. So again, knowing exactly which gene is mutated helps in predicting the risk of not only colonic cancers, but also extracolonic cancers in patients with Lynch syndrome. And this is important for you to determine at what age the at-risk relatives should be screened, at what age the surveillance should start, and at what age prophylactic surgery should be offered to these patients. So surveillance is very important in a patient with a suspected or a confirmed hereditary colorectal cancer syndrome. It depends on the risk of developing colorectal cancer. The method, the age of starting, and the frequency varies between the various hereditary colorectal cancer syndromes. In an FAP, it is all right to start with a sigmoidoscopy, because invariably they will have rectal polyps. Especially in children where you don't want to do a complete colonoscopy, you can start with a flexible sigmoidoscopy. And as and when they start developing polyps, then you can go on to perform a complete colonoscopy. Whereas in attenuated FAP, there is a relative rectal sparing. So sigmoidoscopy probably may not be a good test for them. You need to do a complete colonoscopy. Similarly, Lynch syndrome also, you need to do a complete white light colonoscopy. The age of starting surveillance in FAP should be around 12 years if the patient already has a known mutation. In attenuated FAP, you can delay it further to 18 to 20 years. And in Lynch syndrome, even further to 20 to 25 years, or at least 2 to 5 years younger than the family member who's had a colorectal cancer. So the next question is, at what age would you perform prophylactic surgery in a patient with FAP? There is no definite answer to this. It depends on various factors. The risk of developing cancer and the social issues, the patient preference, whether the patient wants to have a family, the intellectual development of the patient, all these factors should be considered before offering prophylactic surgery to patients with FAP. It also depends on the number of polyps. In a profuse polyposis, where there is more than 1,000 polyps scattered throughout the colon, it is advisable to do it as early as possible. In fact, many people will argue for an immediate surgical resection. Whereas in sparse polyposis, you can do it even a little later, by the late 20s. So the surgical options in FAP, there are 4 surgical options: total colectomy with ileorectal anastomosis, or total proctocolectomy with either an end ileostomy or a stapled or a Hansoon pouch anastomosis. So in general, an ileorectal anastomosis is offered in patients who have fewer than 5 rectal adenomas and fewer than 500 colonic adenomas. Whereas if there are more than 500 colonic adenomas or more than 20 rectal adenomas, then it is preferable to do a total proctocolectomy. Sometimes you might need to do a total proctocolectomy with an end ileostomy, especially in patients with distal rectal cancers or a poor sphincter function, or patients who are going to require radiation. It is not unusual to see patients with mute-YH associated polyposis. And in these patients, the timing of surgery usually depends on the ability to clear the polyps, the number of polyps in the rectum, and whether the patient has got a malignancy or not. Patients who have a rectal sparing can be offered a total colectomy with a ileorectal anastomosis. Do you perform prophylactic colectomy in Lynch syndrome? The answer is no, because the patients can be kept under surveillance, which is an effective measure. And you also have recently now the CAP2 study has shown the chemo prevention possibilities in Lynch syndrome. Is chemo prevention possible in FAP? There is no definite evidence in the literature to support chemo prevention to reduce the risk of colonic cancer or even development of colonic polyps. Whereas in patients who have already undergone surgery with a retained rectum, in these situations, use of Sulindac or celecoxib has been shown to reduce the incidence of cancers in the remnant rectum that has been preserved. So in Lynch syndrome, the CAP2 study has shown that 2 years of aspirin, 600 mg twice daily, can reduce the risk of colonic cancers as much as 60%. Now the CAP3 study is undergoing to see whether the patients can have a lesser duration of chemoprophylaxis with aspirin. So the final part, how do you manage a patient who's already had a colorectal cancer in a familial adenomatous polyposis background? It is managed like for any other patient based on the stage. And the extent of surgery has to be decided as determined by the factors mentioned earlier. The only problem happens is when the patient has got a synchronous cancer, one in the rectum and one in somewhere else in the colon, both are advanced. So you need to decide how you're going to sequence the treatment, how you're going to give radiation, and when you're going to plan the surgery. In colorectal cancer in a Lynch syndrome, again it is managed similar to other colorectal cancers based on the stage. In a colon cancer, either a segmental or extended colonic resection can be done based on various factors like the age of the patient. In a rectal cancer, you could probably do a total proctocolectomy. But again, the risk of metachronous cancers again depends on what is the mutation that the patient harbors. It might be as high as 43% if the patient has a pathogenic variant in MLH1 or PMS2, whereas if they have a segmental resection, where it is, but it is quite low if the pathogenic variant is in MSH6 or PMS2. So finally, what happened to these two patients? The first patient underwent a total abdominal colectomy and an ileorectal anastomosis. It was a PT2N0, and his germline mutation identified MUT1H pathogenic variant. So we counseled his children to undergo genetic testing. His son also was identified to have the same mutation by Sanger sequencing, whereas his daughter did not have the same mutation. And the son is now being advised regular colonoscopic surveillance. The second patient, the young male with 37 years old, he underwent a right hemicolectomy. He had a mucinous adenocarcinoma. The IHC MMR showed loss of expression of MLH1 and PMS2. So then we did a BRAF mutation. There was no mutation detected in the V600E codon. Then we went ahead with the germline mutation testing. There was a pathogenic variant in MLH1. And we tested his his brother. He also had the same pathogenic mutation. So both these patients were started on aspirin chemoprophylaxis, and they are also under surveillance for other at-risk cancers like renal cancers and duodenal cancers. So the practical approach for colorectal cancer and hereditary syndrome: first, you need to suspect that the patient is having a hereditary syndrome. You test and identify whether the patient does have a hereditary syndrome, place the patients on surveillance, and you treat as per the genetic mutation that is identified. Thank you.
Thank you, sir. Two questions. Suppose you are doing surveillance for a relative with FAP. Even if they are not developing polyps, you will do prophylactic colectomy or recommend?
In a suspected FAP, if by age 20 to 25 they don't develop any polyps, then it is unlikely that they are going to develop polyps, and it is unlikely that they actually harbor the mutation. So there is no indication for a prophylactic colectomy in that patient.
How many percentage of the lynch you get polyps?
Almost all the patients go through the adenoma carcinoma sequence, so they do develop polyps, but lesser number, usually around 10 to 20, not more than that.
And how much the multi-gene panel will cost?
I think it is somewhere around 15 to 17,000.
So, nice presentation, sir. So one doubt. We usually give aspirin for cardiac issues as a prophylactic dose. That is around 75 milligram or 150 milligram. Even with that, some of the patients develop CVA, the elderly patients, CVA or that kind of bleeding issues. Do you think you mentioned 600 milligram BD or 600 milligram
300
daily?
mg BD, so around 600 milligrams per day.
600 mg daily, lifelong. Will it add on to other issues other than that? Then can you follow up the patients with a 2-yearly colonoscopy? What do you feel? Which one would be a better option?
I mean, the two are totally different. Colonoscopy is not a preventive measure; it is only a screening measure. Whereas aspirin reduces the risk of colorectal cancers by nearly 60%. We have placed patients on 600 mg aspirin. Touch wood, they seem to be tolerating it well. Most of these patients are young patients. They are not elderly patients, and they are not already on aspirin. Of course, before starting the patient on aspirin, we do a upper GI endoscopy to make sure that there is no ongoing gastritis. And practically, we start with lower dose for the first 2 to 3 weeks, see how the patient is tolerating it, and then we step up the dose to 600 mg BD. 600 mg OD, sorry.
Excellent talk. Just one thing about family screening. You spoke about family screening, saying screening of siblings and screening of children. One very important aspect we forget is screening the parents.
Parents, yeah.
Because patients are young, parents are still alive and well, and we've seen cases where we've screened the siblings and children, but parents have come back with a cancer after 5 years. So, we should never forget to screen one generation after.
True. Thanks for pointing that out.